All right, everyone, good evening. Thank you so much for being here. My name is Dr. Laysel Hall. I hold the position of the NAACP New Bedford branch president. It is my honor to thank you for being here and certainly to appreciate your time for a very, very important and serious topic as you are joining us tonight around prostate cancer and COVID. And so our title for our program tonight is Prostate Cancer Awareness in the Era of COVID-19 Pandemic. We have an amazing group of folks for you here tonight, and it is my honor to introduce you to my friend, Marcy Pina Christian, who is the Human Services Coordinator for the City of New Bedford and long-standing member of the NAACP, past secretary of the NAACP New Bedford branch. When I asked her to be the moderator, she so graciously agreed. So I want to thank you. Thank you all for being here. Marcy, the floor is all yours.
Well, thank you, Laysel. It's a pleasure to be here as well. And for those of you who may be new to one of these prostate cancer awareness events, this is the third one being held in the city of New Bedford. And you also may not know that in 2020, Mayor Mitchell declared the week of November 21st as Prostate Cancer Awareness Week in the city of New Bedford. So it is great that in the city we are taking prostate cancer education and advocacy very serious. Each year we have a distinguished group of panelists, and this year is certainly no exception. So without further ado, I would like to start introducing the panelists, and I also want you to know that the last 20 minutes of tonight's program will be reserved for your questions and answers. So make sure during the program that you are paying attention and you're writing down your questions. When we get to that part of the program, you need only to raise your hand and your questions will be answered. So without further ado, our first panelist this evening is Dr. Shabana Naz. She is the Chief Medical Officer and Director of Infectious Disease for the Greater New Bedford Community Health Center. Welcome, Dr. Naz.
Thank you very much. I just want to make sure you guys can hear me. Thank you for inviting me for this important discussion. As we all know that it is almost going to be 2 years now since the first case of SARS-CoV and the outbreak in Wuhan, China was discovered. 2 years into it, we have done amazing things in time frames of getting treatment, as well as vaccines developed to help mitigate the risk from this disease. One of the challenges in this pandemic, because of lockdown and because especially with access to healthcare in the initial times, especially last year, was transition to telemedicine care. And we found a lot of inequities in different communities being able to access healthcare. And preventative health became sort of on the backside because we had to focus our energies on SARS-CoV-2. So as we have opened up, and I'm sure other panelists will also talk about it, we are seeing more primary care healthcare issues coming to the surface. So the chronic disease, things like cancer screenings, diabetes, hypertension, obesity is all coming up to the surface now, along with trying to deal with the pandemic itself. I want to give some sort of global picture, and then I'll come to the New Bedford data. I am going to try and share my screen. This data is from Johns Hopkins. The numbers are huge. These are global cases, global deaths, and global vaccines that have been administered. So not trying to count all the zeros, we'll give you a perspective. 248 million global cases with 5 million global deaths. And here in the US, we've had 46 million COVID cases with a little over 750, approximately 1,000 deaths. That is huge. And we see this in different parts of the world in different degrees. So definitely a global disease with hotspots, and United States remains one of those hotspots. The overall death rate since the pandemic began is about 1.6%. So unlike the first SARS infection, which kind of fizzled out in a year, was not as widespread in terms of global, sort of the global picture. We saw a higher mortality rate, but it also burned out quicker. This disease is sort of simmering and an ongoing basis. In Massachusetts, this is sort of the data that we can all look at on our state department level data. This is looking at the cases from last year all the way till November 2nd. Now, these are state level data from Massachusetts among our 7 million residents. The first peak was back in starting in February, March, April of last year. We remember the Biogen conference that happened in Boston. That was one of the hotspot events, and then the whole statewide infection that happened. And in the beginning, we had very strict measures. The consequences of what we did here are yet to be seen in terms of general public health cancer screenings. But it brought the infection rate down. And then we saw a much bigger infection and death rate last year around this time. It started peaking after Thanksgiving, kept going on. We started our vaccination efforts with our healthcare workers and our nursing homes in December, and for the high-risk patients in February. But it didn't get us down to the lesser peak that we had prior to that. We had a little bit of an outbreak again in April, May. And then as we opened up in June, we saw another sort of peak that is still ongoing. So in Massachusetts, we are, in different areas of Massachusetts, we are at different infection rates, but we're still seeing a number of new cases diagnosed every day across the state. Now, we do see the benefit of the vaccine, even though SARS-CoV-2 obviously has not sort of gone away. In Bristol County itself, we've had about 1,900 deaths and 81,000 cases, which puts this mortality rate around 2.3%, a little bit higher, but this is again starting from last year when we had a higher death rate initially. And 19,000 deaths in Massachusetts overall with SARS-CoV-2. The story of the vaccine, as we have seen, is that we have been able to be very aggressive with our elderly population and get our vaccination rates high in our at-risk population. We are still struggling to get some of our local population in the New Bedford area getting vaccinated. So we are seeing a pandemic more in the younger cohort than we did originally see back in April of 2020. But despite that fact, what the good news is that people who are getting vaccinated, their death rate is much, much, much lower. So the vaccine, even though we get mixed messages about the vaccine is effective. It is effective in reducing the hospitalization as well as the death rate. We know that the vaccine we don't have any access issues with the vaccine itself, at least in Massachusetts. Overall, the vaccination rate of Massachusetts is 70%, but when we look at New Bedford, we are around 50% overall in our vaccination rate. So I have to stop sharing the screen. So, it's as we see that this is a disease that is here to stay, 24 months into it, it is a moving hotspot sort of target, right? So not only at the global level, at the national level, we see areas like Texas, Florida, California, Massachusetts. There are hotspots nationally and there are hotspots regionally. So New Bedford remains high in terms of infectivity rate. We also want to do better. You know, the state is around 70% and we are 50%. So we want to keep pushing our efforts to get the younger population that always does not feel that the vaccine is important for them because this disease may not hurt them as much, so that we can continue to drive our death rates from COVID in our high-risk population even further down. I cannot even touch upon the social disparities, the economic disparities, the learning disparities that are occurring at this time, and the impact of that we have yet to see. It's also a pandemic of misinformation. People are getting information from sources that, sort of contradict what is scientifically available. And, in New Bedford, I hear a lot, as big as of a town or city it is also a very connected city. Like in my population, I see everybody knows everybody. So they get the same information in their Facebook chats and their WhatsApp chats. And every day, my focus is to just kind of break down that misinformation and get the community vaccinated. I also do primary care, and I can tell you, in my 10 years of practice here, I don't think I have seen as much cancer disease burden as I have seen in last year, because we did not have the same opportunity to connect with patients last year. So people are presenting late in their disease, unfortunately, and that is also adding an additional burden on our community. So I will take any questions now or later. Marcy,
I believe we will be waiting until the last 20 minutes for the questions and answers. So if you do have some questions, please jot them down, and we will continue to keep moving on with our presenters. The next presenter is Dr. Caldis, and I believe Dr. Caldis has been with us on all 3 events.
Yes.
Dr. Caldis is a native of New Bedford with more than 23 years of experience in the primary care field as a provider. Most recently, he has been the Chief Medical Officer for South Coast Hospitals. Welcome, Dr. Caldis.
Thank you. And thank you for inviting me back again for another forum. I think these are important. They do help to get the word out. I know from the prior meetings that we've had, I've gotten people to contact me with additional questions, or even after the meetings, which were face-to-face. A lot of people had a lot of questions that I think they were afraid to ask during the seminar. I share Dr. Naz's frustration with the situation in New Bedford with COVID. There is so much misinformation. The topic has actually come out of the realm of medicine and moved into either a battle of wills or some political agenda. And it's very tough to bring people back when they're, that far out. I have this conversation with patients almost on a daily basis, talking about vaccination. And like Dr. Naz said, it tends to be the younger population who thinks that they really don't need to be vaccinated. And I think that unfortunately, they're not really getting the point that even if you feel that you're not so vulnerable to COVID, you have to think about the other people that you may spread it to. And almost everyone has a loved one or a friend or someone they know that's in a vulnerable population. And so it's a crucial conversation that I have on a daily basis. Fortunately, a lot of people, after building a relationship in primary care, tend to, put a lot of weight on what I say. And I've gotten a lot of people to actually consent to vaccination. We're now doing boosters. I have people calling all the time. I think the boosters has gone over really well. People who have been vaccinated are very eager to make sure that they maintain their immunity and help to protect the population. COVID is one thing that we see in the community in the PCP world. The other thing is chronic disease. And so we're constantly counseling people and examining people and looking out to make sure that we're up to date with recommended screenings. And one of those is the PSA. And unfortunately, there's not a lot of awareness yet about PSA, especially in the Black and the immigrant communities. On a daily basis, I have this conversation. I have a large Portuguese population with, Cape Verdean population and Hispanic population. And I think men are really taken a little aback when they hear how vulnerable they may be for prostate cancer. It's nothing that's ever been spoken, about with them. Even family members who might have had it really didn't discuss it. So they, kind of look at me a little askance at first when I mention it. But as the conversation goes on, I think they become very interested and want to be very proactive. And so I've had, very good luck in getting people to go for screenings, come in even after having a teleconference or a video conference, getting people to come into the office so we can discuss it further and actually proceed with an exam and get them necessary screening. Fortunately, our urologists are, very proactive. And I've seen many of the people that I've referred to our urologist ordering MRIs and ordering studies to try to help better stratify patients so that they can make a more informed decision about their treatment options. I think I'll stop right there. And I know you said that the questions are going to be at the end, but I'm willing to speak about not only a prostate cancer screening, but any of the chronic diseases. If you have any questions.
Seeing none, I'm going to call on my co-moderator, Laisella Hall, to make the next introduction.
Thank you, Marcy. I appreciate that so much. I believe that Tony Cabral is not available right now in the messages, so we'll move right along, and then we will try to circle back with Representative Cabral when he is available. That being said, I'm happy to introduce Dr. Faina Stern, who is president of AdMeTech Foundation. Thank you, Dr. Stern, for your willingness to partner with the NAACP New Bedford branch. We appreciate you. The floor is all yours.
Thank you so much, Dr. Hall, Marcy. It's a pleasure to be it's a pleasure to bring this community educational event, New Bedford, again. Actually, Marcy, I believe it is our fourth event. The first event took place in 2017, I believe, with you and then President Rose of New Bedford NAACP. Then we had a couple of events with you and Greater New Bedford Health Center and Damon Chaplin, who is the head of public health in New Bedford. So it's actually our fourth event. So it's a pleasure to be here, fourth annual event, and it's a pleasure to be here. I'm very grateful for the regional support from Marcy and President Rose, and for the current support from Damon Chaplin and from Dr. Hall, and we hope to be here again in 6 or 12 months. We actually were, I know that Representative Cabral cannot join us because he has electricity problem in his area right now. And in order to avoid electricity problem, all kinds of problems, including internet instability, we pre-recorded my presentation. Before we will start my pre-recorded presentation, though, I would like to acknowledge two members of the AdMeTech staff who have been instrumental in making this event possible, and actually they're managing this event right now technically. It's Thomas Satam, our organizational manager of operations and advocacy and community outreach, and Ali Adam, our health policy coordinator. Ali and Thomas, thank you so much for your work. Ali, if you can please start my video, it would be appreciated. I would like to express my gratitude to New Bedford NAACP, Dr. LaSalle Hall, and Marcy Pena Christian for the opportunity to address prostate cancer awareness in the times of the COVID pandemic. This event is a part of the AdMeTech Foundation's ongoing program in prostate cancer awareness and education in Massachusetts, with primary focus on African American, Hispanic, and Latino men. Our program was initiated since 2014 with strong support from the New Bedford delegation to the state legislature, particularly Representative Cabral, who is participating in this event. Also, I would like to thank leadership of the Greater New Bedford Health Center, represented by Dr. Shabana Nas, Massachusetts General Brigham Healthcare, represented by Dr. Ike Makeda, and Greater Boston Urology, represented by Dr. Ryan Frankel today. Both COVID-19 and prostate cancer have emerged as leading health disparities in Black and Hispanic communities. In April last year, early in the pandemic, we have recognized that the areas of prostate health disparities directly overlap with the pandemic hotspots. Since May last year, we have expanded our program to include education about both prostate cancer and COVID-19. Prevention and early detection are critical for saving lives and eliminating disparities in both prostate cancer and COVID-19. The future of this pandemic depends on us. We can drive down infections drastically by wearing masks, particularly indoors or in crowded outdoor settings. We can end this pandemic by complying with vaccinations. Masks are the best tool we have for preventing spread of infection. If most of us use masks, we can save over 1,000 lives and prevent countless infections by February next year. Vaccines are the best tool we have for ending this pandemic. In mid-September, CDC reported that in fully vaccinated people, infections were reduced 5 times, with hospitalizations and death reduced over 10 times. COVID vaccines have been proven safe and effective in millions of people aged 12 and older. Many experts pointed out that the vaccines could have prevented over 97% of hospitalizations and death we are seeing today. We are much more likely to get into a car accident and sustain a serious injury than develop significant complications of COVID vaccines. Vaccines are the best way to protect not only ourselves, but also our families and our communities. By accepting vaccinations, every individual helps us get one step closer to ending this pandemic. Since early September, more than 5 million children were diagnosed with COVID. By early September, new COVID cases in kids reached record levels. Our masks and vaccinations protect our children. On September 14, Boston Globe journalist Renee Graham wrote an opinion, "The unvaccinated and the orphans they leave behind." She pointed out that over 120,000 kids lost their parents or caregivers to COVID in this country, with Black kids impacted disproportionately. She raised an important question: can we allow our hesitancy and fear of the COVID vaccines define our children's future? Last month, leaders of pediatric medicine issued a public appeal. Pediatricians are advocates for children and protectors of their health. Now we are asking for children to be made a national priority. Preserve their in-person education by mandating vaccines and masks in schools. Protect them with highly safe and effective vaccines.
Over the last 2 weeks, it has been exciting to watch that FDA and CDC advisory panels recommended vaccines for kids age 5 to 11, and they're expected to become widely available next week. On July 27, US Surgeon General Dr. Vivek Murthy shared publicly that he lost 10 relatives to COVID-19. He pointed out, masks help us reduce spread of infection, while vaccinations remain the key to ending this pandemic. While we are dealing with COVID pandemic, prostate cancer cannot wait. And yet many men avoid visits to their doctors out of understandable fear of contracting coronavirus. Unfortunately, delays in prostate cancer care can cause reduced quality of life or even loss of life. Clinical facilities created a safe environment for patient care, including virtual visits and telehealth, ongoing in-person care, such as physician appointments, testing, medical procedures, biopsy, and treatment. Ongoing care is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. However, early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast with late diagnosis, when cancer is spread to other organs, only about 30% of men remain alive at the same time. In prostate cancer, screening with blood test, called PSA, is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. During pandemic, it is more important than ever to take charge of your prostate health. It's important to know your risk factors, such as African heritage, family history of prostate cancer, particularly brother or father, and increasing age, 50 and older. You can ensure early detection. During annual visit, ask your doctor about PSA blood test and digital rectal exam to determine if screening is right for you. You need to talk to your doctor starting at the age of 40 if you have risk factors, or at the age of 45 if you do not have risk factors. Before screening, it is important to avoid exercise or sex, which may impact your testing results for about a week. After screening, you need to ask your doctor if your test is normal or if you need referral to a prostate cancer expert. Several weeks ago, AdMeTech Foundation held a virtual annual global summit on precision diagnosis and treatment of prostate cancer. Our summit has brought together the key international opinion leaders representing every clinical expertise to achieve the following goals: educating medical community and general public, reaching consensus on the best emerging clinical practices and research priorities, and expediting transfer of promising innovations to patients. Screening of prostate cancer with PSA blood test reduced death by more than 50% and has been more successful in that regard than many other established cancer screening programs. Screening results at midlife in men aged 45 to 59 were shown to be particularly important for assessing the risk of lethal prostate cancer long-term within 30 years. Depending on PSA level, the majority of men usually have a low risk of prostate cancer and can be reassured. However, a minority of men have a high risk and need to be monitored closely. In men before diagnosis of prostate cancer, we have seen rapid advances in accurate, non-invasive testing, which created a new standard of care, including blood and urine tests for molecular markers and imaging tools such as MRI. These tests improve identification of men who need to undergo biopsies and eliminate a lot of unnecessary procedures. I think it is fair to say that traditional biopsies blind to prostate cancer and performed without accurate imaging, such as MRI, are slowly but surely moving into the dustbin of history. In this slide, MRI shows prostate cancer lesions and guides biopsy needles with precision. Our summit highlighted the importance of MRI in Black men who are likely to have lesions in the front part of the prostate that are difficult to find by physical exam or standard blind biopsies. Our summit also highlighted the importance of assessing genetic predisposition to aggressive, potentially lethal prostate cancer. Testing for genetic mutations is particularly relevant for men with family history of aggressive prostate cancer and other malignancies, as well as for men diagnosed with aggressive local, regional, or metastatic prostate cancer. Genetic counseling is preferred prior to testing for men with family history and after positive test for genetic mutations. In men with prostate cancer, there are two pillars of the current diagnostics, MRI and genetics. While MRI shows cancer location and spread or stage, genetic tissue analysis reveals underlying cancer biology. With this precision diagnostics, we can now accurately determine if each individual has a slow-growing, harmless disease and needs only careful observation, or an aggressive prostate cancer requiring immediate life-saving treatment. More recently, molecular imaging of prostate cancer has been shown to play an important role in detecting return of prostate cancer after treatment or metastatic spread. PSMA imaging has been approved by FDA only a few months ago and become available at the Dana-Farber Cancer Institute since August. On the left, identified as A traditional bone scan shows limited metastasis. On the right, identified as B, molecular imaging shows much more extensive disease. This information is important for treatment planning. Recent large study in over 100,000 men in Veteran Administration health system showed that with equal access to care, there were equal prostate cancer outcomes, including equal probability of death in Black and white men. And this health equity was independent of the level of education or income. Similar results have been reported in military medicine. Based on this and similar evidence, our summit concluded that access to care is the key factor in eliminating health disparities. We recently expanded our community education to include a program for improving access of high-risk men, particularly African-American and Hispanic individuals, to high-quality clinical care. We have been working with men to match their individual needs with leading state experts in patient care and research who have the most advanced diagnostic and therapeutic resources available today. Our clinical care equity program is open to any high-risk man who is interested in consulting a prostate cancer expert to address every aspect of their prostate health. This consultation may include an initial evaluation or a second opinion, virtual or in-person visit. You will benefit from this program if you are not sure prostate cancer screening is right for you and seeking more information. If you had screening already and have questions about your results and the appropriate next steps. If you have been recommended an invasive biopsy and seeking more information about the related options in order to make an informed decision. If you have family history of prostate cancer and have questions about genetic counseling or testing. If you were diagnosed with prostate cancer and would like to learn more about treatment options. If you experienced complications after biopsy or treatment. If after treatment you have questions about the next steps, including prevention or early diagnosis of cancer return or progression. Summer Mills, a member of the AdMeTech Foundation staff, serves as a statewide clinical coordinator. If you have any questions, please contact Summer by phone 617-523-3535 or by email equityprojectcoordinator@admetechfoundation.org. In summary, prevention and early detection and related public awareness and education save lives and reduce health disparities in both COVID and prostate cancer. Masks and vaccinations prevent COVID infections, hospitalizations, and death. Advances in screening and diagnosis created a precision, individualized approach to prostate cancer care. Thank you for your attention.
Thank you, Dr. Stern. Thank you for the wealth of valuable information that you shared. And to those who are watching this program today, what Dr. Stern just shared is just so valuable, because I think most would agree having the right doctor is everything, is key. And the fact that you can call AdMeTech and be paired with an expert, that is huge. So if you're there and you're fearful, please heed Dr. Stern's advice and call AdMeTech. And again, Dr. Stern, I want to thank you for your groundbreaking research and leadership. If it was not for you, we would not be here today. If it was not for you, we wouldn't have Prostate Cancer Awareness Day in New Bedford. It is you reaching out to the NAACPs across the state with your passion, with your commitment to eradicating the deaths within communities of color. It is that fierce advocacy that has brought us all here today. So for that, I want to thank you greatly for the work that you and AdMeTech is doing. You are saving lives. We will move to our next presenter, who is Ikena Kal-Maduke, MD, PhD, urologist and fellow, combined Harvard program in urology, oncology at Massachusetts General Hospital and Brigham and Women's Hospital. Welcome.
Excellent, thank you. Let me share my screen here. All right, good evening, everyone. So just by way of introduction, prostate cancer is the most diagnosed malignancy in men in the Western world, and the second leading cause of cancer-related deaths in men, with about a 1 in 9 lifetime incidence. PSA is a secreted protein that's role is in the liquefaction of seminal coagulum. Was discovered in Japan in the 70s, and about a decade later was used as a serologic test. About 6 years later, the FDA approved it for the detection of treatment recurrence. And then a little bit after that was used for early detection of prostate cancer. The graph you see here just shows a spike in the incidence of prostate cancer. And this was after the advent of PSA. So we were able to pick up more men. And you can see it slowly starts to decline with the treatment of men, which we can all agree that was probably too aggressive. I think we're treating all men with prostate cancer. As we know, all prostate cancer is not equal. And so there was a lot of data that came out that showed that, essentially that we were overtreating men and subjecting men with low risk disease who were not going to die from the cancer to the side effects of treatment. And so in 2011, the US task force essentially passed a recommendation saying that we should no longer check PSAs and men should no longer be screened. It didn't take long to see the effects of that blanket recommendation, which was that we started seeing men presenting with regional disease and distant disease, similar to the pre-PSA days. And so rightfully so, the US task force backtracked on that recommendation and now said that PSA should more likely be an individual decision between the patient and the physician. And so I think we agree that PSA is not a perfect test. You know, there are other things that can cause PSA to be elevated. One is just an enlarged prostate. You can have infection in the prostate, you can have just inflammation, instrumentation like a Foley catheter, or riding a bike or having an exam can falsely elevate the PSA. And so we know it's not a perfect test, but it's not a bad test. There are several adjuncts out there that have helped to increase prostate cancer screening, and we'll touch base on that soon. Nonetheless, the 10-year survival for prostate cancer is about 98%, so very good. And that's because the vast majority, around 90%, are diagnosed in that local or that regional stage. It's just starting to creep outside of the prostate. However, if you're discovering and it's gone to the other parts of the body, then that survival drops significantly to about 30%. So our goal is to make sure that men are not in this region here where that cure rate is drastically lower. So Whitmore was one of the, considered one of the founders of urologic oncology, actually died from prostate cancer. And he had these sayings that were called Whitmoreisms. And as it pertained to prostate cancer, is paraphrased here. He had 3 questions. And the first was, after a diagnosis, is cure possible, right? And the second question was, well, is cure necessary? Again, all cancers are not created equal. And then finally, if cure is possible, when it's necessary, right? So if you think about prostate cancer in that context, it helps to direct, our recommendations and our and how we guide our patients. And so to that regard, we'll talk about advances in detection and risk stratification, and advances in treatment. With regards to treatment, we'll just touch base on surgery, radiation, hormone, and immunotherapy. So again, there are many markers out there, some for the blood, some for the urine, and in tissue. We'll touch base on just one of these tests in urine, just to give an example of some of the shortcomings, and then we'll talk more about MRI, which is probably the best study and probably has the most upstage for advances. So this was a group that a multi-center trial out of Colonel's group that showed that the use of percent-free PSA actually increased the ability to detect overall cancers over total PSA. And so on the surface, that might sound great, but let's move this on here. What we actually saw was that we're unable to differentiate between high risk versus low risk prostate cancer. So bringing us back to our initial problem, which is detecting cancer that does not need to be treated. And so this example here of free PSA, sure, you're increasing the detection, but you're detecting cancer that you might not necessarily treat. And so we'll switch over to multiparametric MRI. Which you don't think of in the concept of a biomarker per se, but it's you should think of it as that. And so multiparametric MRI actually performed better in detecting clinically significant disease compared to these other tests. And not only that, it was able to reduce the amount of men who actually would undergo a biopsy. And so about 1 to 2% of men who undergo a biopsy will have complications related to that biopsy, whether that being admitted in the hospital for IV antibiotics, needing a Foley catheter, intractable bleeding. So it's not without consequence. And so to be able to decrease that by about 30% is not insignificant. With regards to finding cancers that we don't necessarily treat, you're looking at about 9% compared to about 22% in your standard 12 core. Now, how does this relate with regards to negative predictive value? Meaning that if you get an MRI and there's no lesion there, how does that really perform? What is the standard truth? And that depends on how prevalent the disease is in the community. And so what you appreciate here on this side is that as the disease becomes more common, that negative predictive value goes down. And so you have to use it, with a grain of salt with regards to the ability to say this negative test is negative. And so with that regard, we're not at the point where we can substitute an MRI for that, at least for that initial biopsy. I think most people will still do either a fusion, so combining the MRI and the ultrasound, at least for the first one. And then subsequent biopsies, you can trade MRIs and biopsies. With regards to detection of the actual biopsy, one of the advances that we have now, still not globally accepted, but we're moving towards that route, is to perform a biopsy transperineally. So usually, if you had a biopsy before, you might have had a probe go through the rectum, and through the rectum, you have your biopsy gun go through the rectal wall into the prostate and get your sample. And so you're crossing over bacteria that's in the rectum, and that's where some of these infections are happening, and resistance to antibiotics. And so what most people are doing now is you're still putting the probe in the rectum. However, you're sampling through this area right here. And so you're bypassing the need to have to go through the rectum. And clearly you're reducing infection risk that way. With regards to targeting, which was alluded to with the prior speaker, you have lesions over here in the anterior prostate that might be hard to get to, which is traditional route going through the rectum. And so you're able to sample better these difficult lesions that are far away. And so not globally accepted yet, but probably in the next few years, this will be the standard of care for biopsies. I put this up here, not for you to read the small print. This is the NCCN risk stratification of prostate cancer. From here for intermediate risk all the way to high and very high, I think it's clear what the standard of care is. You need treatment. This region here is where there's more wiggle room and more room for improvement for regards to risk stratification. And this is your very low and low risk. And so this is where some of these adjunct biomarkers can play a role. I'll just briefly touch on some of those here. Polaris, that looks at the some cell cycle progression genes, and that predicts the risk that if you do nothing, what's your risk that this prostate cancer will kill you in 10 years. Oncotype DX, that looks at your gene, your genetics. So it gives you a score, and that predicts the risk that if you were to have surgery, what is the risk that the outcome is adverse? So, your nodes are positive, or the margin is positive, or the prostate cancer is actually spreading out the prostate. Decipher, that's again in the post-treatment phase. And what's the risk that this disease will spread to other parts of the body? And now we're actually moving closer to where we're using this in the biopsy phase. So those are what we have, of course, with regards to advances in the staging and risk stratification. We'll move now into treatment. We'll talk about surgery and then briefly in radiation, hormones, and immunotherapy. So from a surgical standpoint, some people still do this traditionally open, where you have a incision down here, and you're able to take the prostate out. Most people now will do this robotically using the Da Vinci platform, which you have here. So the surgeon sits on the side. He has an assistant at the bedside with the patient. The patient is here. You have about 5 to 6 ports. This middle one here is the biggest one through which the prostate will come out. Most men will go home the next day. In the era of COVID, men are going home on the same day. And it hasn't been a problem in regards to having to come back to the hospital or anything like that. From an advanced standpoint in regards to surgery, this is still part of the Da Vinci platform, which was called a single port. And so now men will have one incision and one trocar, and through here the arms will go in. We've shown that from a cancer standpoint, there's no differences in regards to oncological outcomes. This is not a painful procedure per se, but even with this technique, men use even less amounts of pain medications. This is another angle here. This is out of the group in Cleveland. Again, you have one incision. It's about 2.5 centimeters. Through there, you put your trocar. Yeah, those multiple arms you see on the other side, they all go through this one trocar. They expand on the inside. You can perform your surgery. And again, the outcomes are the same. And most men will go home on the same day. Another advantage here is typically in the other part, you have to tilt the head down. So all the intestines and all the bowel can fall down so you can work. With this, you're able to keep the patient flat. And so some patients who cannot tolerate being flipped upside down, this is a good alternative for them. We'll switch now to radiation. So again, you have brachytherapy seeds. Usually this is used in combination with external beam, plus or minus hormones, depending on the grade of disease. Proton beam is still deemed essentially experimental, and it's not really used in a lot of sites. So that's not common. With regards to advanced prostate cancer, again, this is cancer that's spread outside of the prostate. Androgen deprivation or taking away testosterone is still the mainstay of treatment. Unfortunately, for a lot of men, as they get treated, they almost invariably will get to a point where the cancer no longer responds to removing its androgens, and so they need further treatment. With regards to advances, relugolix was the first oral GnRH antagonist. The other ones are usually intramuscular. This was approved last year, last December, and it has been well tolerated. In the immune space, CYP2 was the first immune therapy for prostate metastatic cancer. Here you take the patient's cancer cells, you bring them out, expose them, and have them make antibodies that target the cancer. You put it back in the patient, and it's able to find the cancer cells that way. Pembro was approved in June last year, and this is for a subset of patients who might have this PD-1 or PD-1 ligand expression, and has shown promising outcomes. Two newer ones, rucaparib and olaparib are PARP inhibitors. This was approved last year in the metastatic cancer space. And again, this is for a subset of patients who might have mutation in the gene that corrects for DNA gene mutations. So again, promising outcomes there, and new advances in the prostate cancer advanced space. From a imaging modality, this has been touched on already, but we'll just go back over it again. PSMA PET. This was actually approved. The first delivery agent was approved last year. At that time, it was initially at 2 sites in California, UCLA and I believe UCSF. And what you appreciate here is this is your traditional bone scan, and you can see clearly these dark spots are where cancer is. So some cancer here, maybe some cancer here, some cancer there. But you can see that the same patient with the PSMA PET has cancer everywhere. And so this will guide the sort of treatments that you offer patients. And more recently, a second agent has been approved in May of this year. So Dana-Farber has the PSMA PET, and I believe MGH will be getting it as well. So in fact, with this new agent, anywhere that can perform PET scan should in theory be able to perform this test. So it's going to open up the ability for this test to be performed essentially all over the country. And so with that, just a few conclusions. You know, PSA-based screening still remains the standard of care. It's not perfect. Using some adjuncts, whether it's biomarkers or MRI, will help to better risk stratify patients. We've made advances in the surgical treatment of localized prostate cancer. We've made several advances in the treatment and detection of advanced prostate cancer. And cancer research is ongoing to still improve on risk stratification and treatment of these patients. So, thank you.
Thank you, Doctor, for that detailed information. And I am now going to circle back to Laysel Hall for the next introduction.
Thank you, Marcy. And again, thank you, Dr. Medecki, for that wealth of information. I certainly appreciate the images, as I learned kind of by imagery as well. So thank you for that. Not only the words, but the imagery. Again, thank you for being here. Certainly allow me to introduce Representative Tony Cabral, who's chairperson and joint committee on state administration and regulatory oversight. Representative Cabral is also a champion of the prostate cancer educational program for high-risk men, with the priority of focusing on African-American, Hispanic, and Latino individuals. We're happy to have Representative Cabral tonight with us. Representative Cabral, the floor is yours.
Good evening, LaSalle, and to everyone. Sorry, I'm not sure on my cell because I'm still out of power at the house. About 600 customers around here, so I can't use my computer. I have no Wi-Fi, but I really trying to get on the program with you. This is I was able to see the last panelist and part of the presentation. Fantastic presentation. The information that was shared is really informative. So I'm hoping folks listen carefully. They follow all the recommendations. This is really the kind of cancer that can be, if it's detected early, obviously the success rate is great. So programs like this one, awareness programs, making sure that men do get screening. In particular, as LaSalle mentioned, the highest rates in our area and other parts of the country, obviously, has to do with the African Americans, Latinos, Hispanic versus white men. So it's that much more important to get the message out to all our communities of color, making sure that that they are aware of what can be done, how to go for screening, how important it is to screen early, and so I think that's what we need to do and continue doing every year. This program, before COVID, we did it actually at the Wheeler Museum last year. Hopefully, once COVID is over and we are able to do it would be nice to do an in-person event and try to get the kind of crowd that we need to make sure that men and women, they follow through. Sometimes that's what you need. You need a coach making sure that they do go for those screenings, they do go and get educated on this matter. It's very important. I had, a bunch of other prepared remarks. So I just want to thank everybody on the panel. Thank you, Dr. LaSalle. And of course, Marcy, she's always been involved in this program from the beginning. And all those who are attending, a big thank you to everybody. I think this is something we're going to continue pushing and doing every year.
Thank you so much.
As you can see, I'm doing it by candlelight. Literally, I got two candles here above me.
Well, we appreciate you, Representative Cabral, your certain support on this very serious topic, and we understand that you're having a little bit of adversity, so we all have a little patience and a little grace, but we thank you for getting on the call. Marcy.
And we are right on time, so we don't want to lose that momentum. We have one more presenter left, and that is Dr. Ryan Franco, urologist and prostate cancer expert at the Greater Boston Urology, serving Southeast region of Massachusetts. Welcome, Dr. Franco.
Thank you for having me. I've had the opportunity to speak at a number of these forums now, and Dr. Stern has been kind enough to invite me, and I enjoy having the chance to speak to all of you. I come speaking with a slightly different perspective. I work in the community. I work in Brockton, and so the patients that I see get referred, directly from their primary care physician. A lot of the A lot of the other doctors you may hear from are working in Boston in tertiary care centers. They're taking care of more complex patients. But usually myself and my partners, whether you're in Brockton or New Bedford or in various communities around the state, around the country, the first line of defense for the management of prostate cancer are those of us in the community. And one of the things I want to discuss is the need for screening for prostate cancer. I think that those of you that are observing this, it's important that that you're aware of the need to screen. There was some discussion previously about a significant increase in the rate of regional disease, distant disease, because of a decreased rate of screening. And so, and a lot of that certainly had to do with some of the guidelines that had changed, and the USPSTF, United States Preventative Services Task Force guidelines related to stopping PSA screening, and absolutely that has had some negative effects on screening. But I think there are some other misconceptions in the community regarding screening and what happens when you get screened. And so the screening test is a PSA test, and there remains to be some controversy as to whether that should be done. Not a controversy amongst those of us in the urologic community, but rather there's controversy in within the primary care community. And so if there's something that you take away from my talk today, is that I'd like you to be your own advocate as a patient, as you're a man between the ages of 50 and 75, any man, but certainly men of African-American heritage are at higher risk, to be your own advocate and ask for the PSA test to be performed. Because this is a test that can save lives. You heard about that prostate cancer is the second leading cause of cancer death in men. And so a very simple blood test, which you're probably going to have otherwise for other tests, cholesterol, perhaps tests about diabetes, about your kidney function. You can also check a box and get the PSA test. And I think that's very important. I think there's a concern related to PSA testing in regards to what are the results of this? What am I bringing on to myself if I have a PSA test? And certainly, I think a lot of the men that are listening today, associate prostate cancer treatments with erectile dysfunction, and I think that's a real concern that I hear from patients. Obviously, it's an important issue. And so I think that what's important for those of you that are sort of on the fence, if you don't want to have a PSA test, again, I want you to be an advocate with your doctor, but there's some of you, your doctor may suggest it, and you might not want to because of that concern related to losing your erections. And it's important to understand there's a lot of steps that happen between the point of prostate cancer treatment and the PSA test. So you have a PSA test, the majority of men are going to have a normal PSA and are not going to be recommended for a prostate biopsy. Those men that have a prostate biopsy, the majority of men are not going to have a negative biopsy, and they're not going to have prostate cancer. For those men that have a positive test, in today's world, the majority of men actually will not get treatment. They'll be placed on what we call active surveillance, and they'll be watched. And we do that because we know that there was a lot of overtreatment for prostate cancer in the past. And what we're really looking for is those men that are at higher risk of death from prostate cancer. And we have a lot of different tools that we use to try to identify who are those people. What does that tissue look like on pathology if you look at it under a microscope? What is the PSA test? There's reference to a lot of molecular tests that are now being used and are very valuable. But for those men that end up having an elevated PSA, then end up having a positive prostate biopsy, and then having characteristics of their cancer that are worrisome, these are the men we want to find, you know, and some of the people participating in this forum today, you may be listening, but you don't know that you fall into this category. But it all, that process only starts with having a PSA test. But just because you have a PSA test does not mean you're going to lose your erections. Far from it. And so there are a lot of steps that have to happen. And frankly, for those men that we identify that are at high risk, we're hopefully going to save your life. Hopefully, we're going to be able to have effects that are going to allow you to live a longer life. As far as those treatments that are out there, you know, none of these treatments are benign. None of them are without what we call morbidity or long-term side effects, and that's a legitimate concern, which is why we are more apt to place patients on active surveillance protocols when possible. But you know, the alternative is much, much worse if you are in that category of men that would really benefit for treatment because you are at higher risk. So again, in summary, as a member of the community and a community-based urologist working in a community like New Bedford in Brockton, I want you to be an advocate for yourself. I want you to talk to your doctor about PSA testing. I want you to ask your doctor to have that test performed, because as I said, there are many doctors that still don't want to do it. Excuse me. And I want you to understand that prostate cancer screening could save your life. And only in those patients that are going to reach that point are they going to potentially have negative side effects from the treatment. But the vast majority of men are not going to reach that point and therefore are not going to be harmed by the PSA testing. Thank you.
Thank you, Dr. Frankel, and thank you for reminding us all that we are our own best advocate. I think that is valuable information to share. Thank you again to all of the panelists. Let's give them a hand for the information shared. And we are now into the question and answer period of our program. And I am going to ask Dr. Stern to manage that part of the program.
Great. Before I of course, I have a lot of my own questions for Dr. Frankel and Dr. Madeke, but I am wondering if we have any questions to me or to other physicians, to Dr. Nas, from the panelists or from the audience.
We have nothing on Facebook so far.
Okay, very good. Any questions from the panelists?
I certainly have several, Dr. Stern, but I think I saw Dr. Rose's hand up. Dr. Rose, you had a question? You're on mute, Dr. Rose.
Yes, I was just wondering, do you have any sufficient indication of the extent to which the COVID pandemic has impacted the early detection of prostate cancer? I mean, just how much has the pandemic exacerbated the delayed detection and treatment? And I'm speaking either for the state or New Bedford or both.
That's a great question. My colleagues across the country are sharing me that they've seen the drop in screening during the pandemic by 40 to 60%. I'm not sure if Dr. Madeke or Dr. Frankel will agree with this number, but that's the number I hear from a lot of colleagues. I will ask them as well to comment. At the same time, we started seeing increased number of diagnoses of prostate cancer, which appears almost paradoxical because the number of testing went down. And the best guess, we are not exactly sure what's behind it, but the best guess, I think in 2021, increased numbers may be associated with the catch-up testing after pandemic. Dr. Madeke, Dr. Frankel, would you like to comment in your clinical experience? What did you see any drop in screening and to what extent during the pandemic?
I can speak to that. You know, I think that the telehealth process was very valuable. Obviously, people were trying to avoid coming into the doctor and potentially being exposed to COVID. But the problem is that you know, you can't do a PSA test. You certainly can't do a prostate biopsy via telehealth. And so, so while telehealth was very valuable and is very valuable as far as doing consultations, there, you know, it has its real limitations. And so, you know, in order to get a blood test, you need someone to take blood. And so where that fear was there, and legitimately so, that really, I think, impaired screening. And so there may have been patients that were having telehealth visits with their primary care physician, but they weren't getting any testing in addition to it. And so really those types of issues that were being addressed were those issues where people were symptomatic. PSA testing is not for symptomatic patients, therefore it's for the general population of men. So yeah, I think that I personally am seeing the same sort of thing. I would say that last year, I did a lot less prostate biopsies. I really did, because a lot less patients were getting the PSA testing. This year, I'm doing a lot more. I think I'm doing more prostate biopsies this year than I have at any time in my career. And I think it is because of this catch-up testing, which, you know, while unfortunate that it fell behind last year, at least it didn't disappear altogether.
Dr. Madeke, would you like to comment?
Right, sure. I think as well, we saw a decreased referral pattern. Just patients were not going to their PCPs, and so we just weren't getting those referrals. But that has picked up since then. From a treatment standpoint, you know, we've shown previous data that it takes about 9 months from diagnosis to treatment for you to see adverse outcomes with regards to, you know, positive margins or the disease going outside the prostate. Now, this is from diagnosis. And so that's a number we kind of quote for our men is from time of biopsy to treatment, you have about 9 months. And that's previous data. We looked at our data here at Brigham during the pandemic period where men might not get on the schedule as fast. And we didn't see an increase in adverse outcomes. So once they're here, even though we might not operate as fast, we didn't see an adverse effect there. But definitely we were seeing less men coming in by virtue of not being screened by the PCPs.
Yes, Dr. I think Dr. Hall had a question, and then Dr. Naz will have a question. Dr. Hall?
Yeah, sure. Thank you again, Dr. Stern. My question was for Dr. Naz. Earlier, you were again talking about the rates of COVID-19 in New Bedford. I guess I was going to ask you, why so high? Can you talk a little bit more about why you did say they were so high? I think that's important for the audience to be aware of as to why we're seeing that as compared to other parts of the state.
Are you talking about COVID-19?
Yes, COVID-19.
I think that what we have seen in communities that have households which are living together and multiple households living together, which we know in New Bedford, that is the case with a lot of our community members, especially the ones that we serve at the health center from that socioeconomic stratus. There are multiple people that are living together. In the beginning, our pandemic was quite driven by people who were working in certain areas. So, for example, we saw a lot of people in fish houses that were essential workers, and the conditions that were there that were driving people to get infected at work, and then they were coming home, and then their households were getting infected. And at that time, you know, that was the driving force. Our testing was limited. You know, a lot of people were sick, and we were doing a lot of telemedicine. We were also afraid, and people were not coming in to get seen. So I think that first phase, once that has died down, COVID-19 variant, the Delta variant was more infectious. It became more of an issue. And some of our behavior really has not changed, right? So our vaccinations rates still lag. And that is, I think, such a multiple level tiered question of why are we at 50% in New Bedford versus the state is at 70%. So we could probably dig deeper into the misinformation, into the hesitancy of vaccines and such. But I also wanted to comment, I'm a primary care physician. I do infectious disease, but most of my practice is primary care. I think, access has been an issue. The constant screening, do you have COVID-19? Are you in quarantine? Are you not in quarantine? That kind of delayed a lot of the process in people coming and getting their lab testing done. The labs, we couldn't just have patients walk into our labs. Dr. Caldis, I don't know if he's still here, like even for South Coast, people have to call and make an appointment to get to a lab. So I think some of those barriers that were important to mitigate the risk in healthcare for infection control also led to people not coming in for their labs, even though we did a telemedicine visit and we ordered these testing, right? So some of the places were not working, things were consolidated. I don't know how the bus schedule and everything that was working at that time also affected, at least in New Bedford. And I live in Easton, so Brockton is in my neighborhood, and I think that was also the case in some of the city there. COVID impacted us a lot, right? So, and I think that ended up driving people not getting tested and delays in testing to some degree also. And, PSA and prostate cancer is one of those issues, but it's also all the other chronic diseases that caused a delay in diagnosis, and primary care and the gap of getting patients appointments with a referral specialist got even more and more. And now everybody is so busy, it's just hard to get an appointment for some of our patients on a time frame that, pre-pandemic, we were able to just call and get an appointment, and now there are delays in that too.
Thank you, Dr. Naz. I appreciate it.
Thank you so much, Dr. Naz. Any other questions from the panelists? Okay. I actually have a question with for Ike Madeke. Dr. Madeke, would you like to comment with all the emerging liquid diagnostics, blood and urinary tests that can be administered after screening? We call it diagnostic test because screening is PSA test is administered in healthy men. If there are questions about screening tests, then we proceed with diagnostics. Given all the evolution of diagnostic tests that we've seen, blood, urinary tests, MRI, and their impact on selection of patients who need to have biopsy and elimination of unnecessary biopsy, improving diagnostics, including genetics, etc., for people with prostate cancer, so we can actually determine which men should have treatment, which men should not have treatment. We've addressed a reasonable concern that U.S. task force had about unnecessary biopsy and unnecessary treatment with evolving diagnostics. But given all this evolving diagnostics over the last 4 years, did they actually make the last set of recommendations that were still not very positive towards PSA from U.S. task force actually not very relevant today? Please make sure you're on mute.
As you alluded to, there's a plethora of tests out there, which, for the most part, I think it's for men who want to avoid treatment and are probably fine avoiding treatment. And so what do I mean by that? That gray area of the 3+4s, or I think most people will treat 4+3. So low volume 3+4, the 6s. I think we can all agree that at least for the 6s, you should watch those, put them active surveillance. Now you might have a conundrum where a patient might have a PSA of, say, 12. It's a small gland, so high PSA density, but then it's Gleason 6 in 3 cores, and so that data doesn't merge quite well. And so that's in a patient where, well, I want to put you on active surveillance, but I'm just not comfortable based on the PSA. So that's a guy who, sure, I would get a second test, an ancillary test, maybe a genomic test. So your Decipher score says you're high risk. So your H&E, the pathology says Gleason 6, you're a PSA of 12, so I'm on the fence. So I get a test in there to put me one way or the other. And if it comes back as low risk or high risk, then that points me one way or the other. For a patient with 4+3 and a PSA of 4, that Gleason 4 pattern we know will kill you, right? So I'm not putting that guy on active surveillance. So all those tests out there, I'm not ordering for that patient. It doesn't help me risk stratify. Now you have patients who would tell you, well, doc, I'm not ready for treatment. And so you might get it in that patient, but really your treatment or your recommendation does not change. So I think it's those tests are useful in the patient who ultimately you probably find put in an active surveillance. The 3+4 is a gray area. There's different schools of thoughts. Some people will not put any 4 on surveillance. I think that recommendation changed from the NCCN a few years back, where again, PSA under 10, less than 3 cores, less than 50% any core, sure, you can probably put these patients on, with a caveat that probably about half of those patients will progress on treatment. And again, that's the patient who you might get ancillary tests to better risk stratify them, with the caveat that you probably will need treatment anyway. And so that's how we tend to use those tests, is for the lower risk patients who you're probably already comfortable watching. Anyone else 4+3 and higher, they need to be treated. Now, if you get a test like Polaris, or a test that says, well, your adverse pathology is probably high, or you suspect that they probably have disease outside the prostate already, well, ancillary test doesn't really help you as much. Now, the PSMA test, and that's going to change how we practice. With regards to, well, your PSA is 20, but your standard CT scan shows that it's all in the prostate. But you know that patient is going to need radiation because it's probably already outside the prostate. And so PSMA test will probably show that now. The question is, do we still give that guy local treatment in addition to systemic treatment? So I think that's where a lot of this might start to change data management. But I think in regards to whether to treat or not to treat, won't change as much.
Mm-hmm. And yet we've seen significant reduction in biopsies due to better accuracy of diagnostic testing. And we've had a fairly significant increase in shifting from immediate treatment to either minimally invasive treatment or simply careful observation, what we call active surveillance. So as I would agree with Dr. Frankel that we've seen considerable, with all the accurate diagnostic, we've seen considerable shifts over the last few years in patient care, that previous concerns about unnecessary treatment and unnecessary biopsy based on PSA screening alone are no longer really relevant, in my judgment.
I think every man should have an MRI before the first biopsy. We're not there yet, but we're getting there. I think in Europe, that's been the standard of care. Everyone gets an MRI before the biopsy. And so it's targeted in addition to the standard template, at least for the initial biopsy. I think we're getting there now. It's still hard for a lot of insurance companies to pay for that initial biopsy before, for that initial MRI before the first biopsy. But that's where we should go. I don't think we're there yet to where an MRI can replace at least the first biopsy. We know we're going to miss, about 30% of those. There are cancers that are clinically significant that are MRI negative, and there's a lot of data in that space as well. So we're not there yet. So I think most urologists will tell you, sure, we do a fusion biopsy, but that first one needs to include a standard 12-plate template. And
Yeah.
then from there, you can risk stratify and say, well, we'll do MRI this year. We'll just do it, check a PSA, maybe a biopsy in 2 years. But that first one, you still need that because you still miss some diseases that don't show up on MRI.
Yeah. It also is a matter of controversy in medical community because AdMeTech Foundation is very much aligned with National Comprehensive Cancer Network, consisting of top 28 or 30 leading cancer hospitals in this country. And they actually, since 2017, they recommended MRI before the initial biopsy, but not just MRI alone, but MRI in combination, as Dr. Madeke pointed out, with traditional biopsy. So you have advantage of visualization and being able to see cancer with MRI, but for biopsy, but you also do not lose the advantages of systematic, what we call blind biopsy. So in combination, it became a very powerful tool. But the point I'm trying to make, there has been such an incredible proliferation of accurate diagnostic tools. Our summit speakers were very clear that decision for individual men whether or not to proceed with biopsy should no longer be based on screening alone. You need to have liquid testing, blood or urinary testing for molecular markers, and then if appropriate, you need to have an MRI to determine if biopsy is justified. So we had a competition of, in addition to formal presentation during our summit, we also had competition for abstracts for emerging work, emerging research, and one of the abstract that one competition showed that actually molecular imaging was very important to determine when patients, about 146 patients, were going to be placed, were intended to be placed on, let's say, androgen deprivation therapy, which is essentially castration. In about 40% of these men with molecular imaging, castration was eliminated because the disease was highly localized and obliterated the need for even androgen therapy, which decreases testosterone in men, which in turn, testosterone feeds the growth of prostate cancer. Dr. Fractal, do you want to comment on all this evolving diagnostics and their impact on biopsy decisions and treatment decisions?
Sure. In my practice, and I think a lot of people are still getting prostate biopsies based only on an elevated PSA. And frankly, I think that's appropriate, given the fact that, the rate of complication-related prostate biopsy is quite low. And, we're doing additional testing where we're testing rectal cultures and rectal PCRs. There's different ways that we can try to anticipate that. That being said, I think MRI before prostate biopsy is very appropriate, and I think it will move in that direction. I think we all agree that a targeted biopsy alone in someone with an MRI that shows what's called a higher PI-RADS lesion is not adequate. And for those men, and you need a templated biopsy as well, for those men that have a negative MRI where there's no lesion identified, a templated biopsy is still appropriate and should be done. The issue with MRI, as Dr. Maduikin, apologize if I'm not pronouncing your name correctly, the issue with MRIs is that the majority of insurance companies are not covering it prior to a biopsy. And so when you talk about standard of care, unfortunately, the standard of care has different definitions based on who you ask. And still, the insurance companies do have significant sway in that area. And so, and they're basing that information not because they're bad people or they're heartless. They're basing it based on data that they have, and that the cost of getting an MRI and then a fusion biopsy is dramatically higher than getting a prostate biopsy alone. And so, until there's really strong and robust guidelines from organizations including NCCN and the American Urologic Association regarding the need for an MRI before a prostate biopsy, which would then drive the insurance companies to cover that service. I think we're still a while away from that at this time.
I think we can wrap up now if there's no further questions, but I do want to mention that this video will be available for sharing. So I think it's very important that we all share this information. There are individuals who will not attend publicly, but I know privately they will want to listen to this information. So I think it's important that we do share it. I see a hand raised. Dr. Rose, is your mute? I think your mute button might be on.
I got it off. I just had one other quick question. I believe Dr. Madweke, you had posted a 10-year survival rate for prostate cancer. How does the current 10-year survival rate compare to, say, what it was 10 or 20 years ago?
Yeah, so 20 years ago, you're still looking at the high 90s. Now, 10-year survival, you're looking at, depending on your stage or your grade, upwards of close to 99%. The improvement is not in a localized stage. If you look at all comers, it's been good and it's still good. I think where we've made more headway is in the advanced prostate cancer space with the new adjuncts. So the Abbeys and all these Pembro and all these other ones. And so that's where we've made a difference. But the outcome there, you're talking about survival of 4 to 8 months, for metastatic disease. But for localized disease, you're in the high 90s. And that hasn't changed for a while with radical treatment. But again, you have to remember, back then we were treating everyone, even the Gleason 6s. So if you had cancer, we were treating you. So with overtreatment, the survival rates were excellent.
One other comment on that, I would agree that there probably has not been a dramatic change in a 10-year survival rate compared to what was 20 years ago. However, if you compare to 30 years ago, the majority of prostate cancers that were diagnosed were either symptomatic or were detected via digital rectal exam. And so the 10-year survival was actually quite low because the patients that were presenting already had advanced disease. Yeah. And so the change has been less time than that. But nonetheless, there's been a dramatic change in prostate cancer survival, again, with this PSA test and PSA screening that has really kind of changed the survival in a dramatic way because we now can identify localized disease.
If I were to make a take-home point, I would say that it is critical that people have insurance, make sure they have insurance. We are in a state of universal insurance coverage. It is critical what Dr. Frankel pointed out about men being their own advocates. And given all the incredible advances in prostate cancer care, even over the last several years, I would strongly suggest after you have screening, please discuss with your physician whether or not your test is normal or whether or not there are any questions. And in case of any questions, please make sure to be your own advocate and ask your physician for a referral for a prostate cancer expert. And prostate cancer experts will sort out all this, your personal situation and how can be matched with all the advances we've had recently. And once again, I would like, if you have any questions, I would like to invite you to call AdMeTech Foundation, 617-523-3535, and we'll help you match with the leading experts who can help you sort out the next step in terms of screening or after screening or after treatment.
And I think that's a great place to end. Dr. Stern, being your own best advocate and knowing that anyone watching today can call AdMeTech and that there will be a team of experts there to assist you and answer your questions. So with that, thank you again to all of the panelists. Thank you for the information shared. Thank you for your advocacy. And we will keep at this until we make a difference, in the data.
Thank you so much. Have a great evening.